Thank you for joining us tonight for Wine with Women Innovators in Pain Management. We are going to allow just a moment for everybody to get logged in, and then we will begin the program. Again, thank you for coming. We are just going to let everyone have a moment to log in, and then we will begin the program. Thank you all for joining us tonight. We are going to allow just another minute for people to log in, and then we will begin the program. Thank you all for joining us. We will now begin the program with our moderator, Dr. Jackie Weisbein.
Good evening, and thank you so much for joining us this evening on our Wine with WIPM event. And I just wanted to say I'm so excited to have you all join us for our second event, hopefully second of many. This has been such an exciting way to discuss new topics and emerging topics in the field, and also share our all group love of wine with each other. So if you're just joining us, I would encourage you now to open your Beekeeper wine, and that way by the time we start discussing the wine, you'll have it nice and ready and available. It'll have some time to aerate and be enjoyed. If you haven't already started drinking it, like some people. That being said, we'll allow one more minute for people to log on, and then we'll get started. This is going to be an education opportunity with CME available. The goal of understanding how to treat your lumbar spinal stenosis patients earlier and more often with percutaneous interlaminar lumbar decompression. Again, 1.25 CME credits will be available. We'll give you some information on how to do that at the end. In the meantime, I think we'll just get started. Again, if you haven't opened your wine yet, please don't hesitate. Open those bottles, let them aerate, and start breathing so that we can get through this, and then you can enjoy your wine education. We're going to start moving. I'll introduce myself last, but first I'd like to introduce my co-panelists. Next slide, please. Jessica Jameson, our current WIPM president, is a spectacular friend of mine. I'm so honored to call her my friend. She currently is practicing in the beautiful Coeur d'Alene, Idaho at Axis Spine, and again, our president of WIPM. So thank you so much for spearheading this amazing group. And I'd like to introduce everyone to Lindsay Schroer, who is a physiatrist and interventional pain management physician at Restore Medical Partners in Venice, Florida, my home state of Florida. Woo. And welcome to both of you ladies. I'm so glad to be having this discussion with y'all tonight, and can't wait to talk about one of my favorite things, which is minimally invasive treatments for lumbar spinal stenosis. So next slide, please.
I thought she was going to say wine. My favorite things, wine.
I guess okay. My reputation preceded me. I do live in the Napa Valley. So so I'm going to first start out talking about piled or percutaneous interlaminar lumbar decompression. Next slide. I don't know if I get to control the slides, but for those of you who aren't familiar with piled, again, percutaneous image-guided lumbar decompression or interlaminar, CMS is a defined treatment category for posterior decompression of the lumbar spine. It's funny, I was actually doing these cases today, and the anesthesiologist asked why I was doing this, or who's a candidate for this versus the candidates for my patients that end up with my spine surgeon. And so it's awesome. We're going to have this discussion later. Dr. Schroer is going to talk about this. But again, this is something minimally invasive. It's performed under X-ray or fluoroscopic guidance, typically with the assistance of contrast media. And some people have kind of stopped using contrast. But again, the reality, the goal of using contrast in the beginning was to identify that compressed area in an epidurogram, so that when you first start with this procedure, you can see the decreased flow interlaminar, and then once you refresh the epidurogram throughout the procedure, you can see the improved contrast flow. This is for patients who have symptomatic lumbar spinal stenosis that is not responsive to conservative therapy, and it's specifically designed to debulk the ligamentum flavum. Next slide, please. So we're going to talk tonight about a number of different things. We're going to talk about the evidence supporting this, patient selection, evidence-based treatment algorithms, and the evolution of the procedure from when I first trained 10 years ago to now the procedure. And I think, you know, it's important that this procedure has evolved, because I jokingly say that when I first trained, I remember this first time somebody handed me a rongeur and I was like, oh my God, like, what am I doing with this? So understanding that this is something that, you know, you can learn how to do. It is not technically as difficult as it might seem. And that this has evolved because of that. And then understanding how you can forge partnerships with your referring providers, surgeons, things like that, and how to continue to advocate for our patients. Next slide, please. So I'm going to start again, piled body of evidence. So next slide. So one of the things that I think is really important, that when we talk about any procedure that we're going to do, is we want to know what is the long-term durability of this, what are the outcomes, and how do we convince patients that this is not some newfangled technique that I trained on last weekend and I'm going to start doing it. The beautiful thing about mild is that it has been, piled has been around for quite some time. And there are 2 level 1 randomized control studies with data to support it. And these studies include 2-year assessment of function, pain, and safety. So having that 2-year data is important, because then you can say to patients, hey, listen, we've got a lot of information that supports the use of this procedure. And these patients have clinically significant improvement with regard to function, standing, ambulation, and then also their self-reported pain. Most importantly, I think one of the things that we consider, particularly in these patients, a lot of them tend to be older, so they're not necessarily patients who want to have large open surgeries. And so having a procedure that's clinically safe and almost an equivalent safety profile to an epidural steroid injection, I think helps people feel much more comfortable moving forward with something like this. To date, there have been over 30,000 patients treated. And so again, this is a strong volume of evidence and patients that are out there living in their lives much better thanks to their percutaneous indirect lumbar decompression. Next slide. Image guided, sorry. So when we think about these studies, we've compared in the original study, the Midas Encore study, we were looking at a comparative study between piled versus epidural steroid injection. This was 300 patients. Now, a lot of times I think people get concerned or hung up on just, you know, well, this is just something for central stenosis. But the reality is that even in that original Midas study, what we saw was that only 5% of the patients had central canal stenosis only. But almost all of them had hypertrophic ligamentum flavum. Now, it makes sense, right? So if you lose disc height, if you develop, you know, spondylosis, and there's this hypertrophy of the joints, and then that everything kind of just smushes together, there's buckling or hypertrophy of that ligamentum flavum that develops, right? Now, these patients also had comorbid foraminal stenosis, facet hypertrophy, bulging disc, far lateral recess stenosis. But as you can see, if you remove or debulk a lot of that hypertrophic ligamentum flavum, you're removing something that is causing a significant amount of compression in that area. Next slide. One of the great things, again, is that 2-year data. So at 24 months, you can see in this study of 300 patients, we saw a decrease of their ODI, or Oswestry Disability Index, by 32 points, as well as their numeric pain rating scale decreasing by 5 points, and sustained at 24 months. So important to note that it wasn't just the initial at 6 months, oh my God, I'm doing better. It was 6 months and then sustainable over a 2-year period of time. Next slide. One of the things that we also see is that of these patients, we had 85% of the patients that had reported some degree of patient satisfaction. Now, if you are like me and you practice predominantly interventional pain, you know that you are not going to please 100% of your patients. So statistically speaking, if you have 85% patient satisfaction, that's an amazing number. And I think this is something, again, that was sustainable over 2 years. Next slide. Other things we talked about briefly, so adverse events. The reason that we can say that this procedure is statistically equivalent to a safety profile of an epidural steroid injection is that there were really no significant adverse events that were discussed. Only 1.3% of patients experienced that, which is similar to the numbers that we see with epidural steroid injections. And you know that there are thousands upon hundreds of thousands of epidural steroid injections being performed annually. And there was no evidence of a development of spinal instability over the 2-year period, which is, again, something important because we want to make sure that, if we are debulking a ligament, is it going to create some instability? And the answer is no. We do not see a development of spinal instability at 2 years. Next slide. So another study that was performed at the Cleveland Clinic with 1-year outcomes demonstrated a couple things that are important. Now, it's funny, I spoke to a patient today, and when he's now like 2 weeks out from his procedure, I asked him, just kind of talking, how long can you stand? He's like, oh, I was only able to stand for 8 minutes. And I said, oh, 8 minutes. And he goes, but prior to the procedure, I could only stand for 2 minutes, right? So understanding what patients' baselines are is really important. And you can see the average stand time for patients prior to the procedure at baseline was 8 minutes. And that's a 600% improvement up to 56 minutes at 1 year. So again, remembering these patients I tell patients all the time when there are limitations, like, if you haven't ran a marathon in the past 10, 5, 20, 30 years, you're not going to have a procedure and suddenly run a marathon regardless of what the procedure is, right? A lot of this is endurance and things like that, but having a 7-time increase in their standing time is pretty significant. But if that's significant, think about this. If they were only able to walk 240 steps at the beginning of a procedure at baseline, we see a 16-time improvement in their walking distance at a year. So one of the things I encourage my patients, like this study, is that after the procedure, we start them on an increased exercise regimen, walking regimen, so that they can build their endurance and actually develop this improved quality of life. Next slide, please. Again, one of the things that I know I keep harping on is the safety comparison. So at 2 years, we can see with piled compared to Superion versus X-stop, there have been less reoperations, less device and procedure related AEs, less serious AEs, no spine fractures. So obviously, we're dealing with spinal stenosis in a patient base that tends to already have other things like osteoporosis, and unless you have the ability to go and put cement in every spinous process before you put a device in, but again, 0 lumbar spine fractures, and there's no implant, so there's no hardware removal. Now, one of the things I think people ask is like, oh, well, if I am doing something there, does this prevent any additional surgeries? No, if God forbid down the road your patient needed to have an additional surgery, this does not prevent them from anything else. But you can see in the comparison between these various decompression strategies, there have been much less issues. And that's, I think, something important when you're talking about safety per procedure. Next slide, please. And I know we keep talking about compared to an epidural, and I think the reason why is because I think people feel like maybe this procedure is not that easy, but when we think about the ease of something and adaptation, I think the more you learn how to do it, the more comfortable you get with it, the easier it feels. I was talking with someone today, I'm a physiatrist. I did not learn how to do epidurals in the middle of the night on pregnant women who were bent over the bed, and so I don't have the same comfort level doing an epidural without using a fluoroscopy machine. But if you train on something and you get better at it, you become much more proficient. And I think that's something that is really prevalent in most of us. We all didn't start out being great epiduralists. And so, if you think about that and the safety around epidurals, as you develop your skill set with anything, you're going to be excellent at it. And with practice, I think this is a similar a safety profile, right? So only 1.3% epidural adverse events compared to piled, the same amount. So again, no spinal instability, no spine fractures, and very low adverse event rate. Next slide. So again, everything I think I've harped on enough. This is safe, it's easy, it's something that allows you to offer your patients a treatment. And realistically speaking, the only thing holding you back is your lack of training on this. So with that, I'm going to move on to the next slides. And I believe it's Dr. Schroer who's going to talk about piled patient selection.
Thank you. Thank you guys for having me tonight. This is fun. It's a fun way to do a webinar anyway. Patients with lumbar stenosis are candidates for this procedure for the piled. These are our seniors. So I live in Florida. My patient population is a Medicare patient population, age greater than 65. You can see these patients walking a mile away. I too am a physiatrist. I was trained to watch people walk. I watch people walk down the hallway. This is those patients that they're walking with their little rollators, that have the chair on them, and they walk several feet down the hallway and they stop and have a seat. You can see them at the grocery store, bending over the grocery cart. Patients complain of pain in the legs or the back. It's relieved when they sit. So flexion improves pain. Flexion makes people feel better. These patients have tried conservative management. So what does that mean? That's the NSAIDs, that's the muscle relaxers, that's the neuromodulators. They've tried physical therapy. You know, they might have tried an epidural or a facet injection and they failed, and they need something else. Next slide for me. So this is your patient with neurogenic claudication. So that's step one for your candidate, the patient with the grocery cart. Number two, they need to have greater than 2.5 millimeters on their MRI for ligamentum hypertrophy. So what I would recommend is that you read all your own films. That's what we tend to do. Our radiologists don't comment on our films and say this patient has, you know, 3.5 millimeters at L4-5. Sometimes they will if we ask them, but it's not consistent. All of the packs that we use, they generally have a measuring tool where you can measure the ligament yourself. And so on the right side, you see the axial view. This is a T2 weighted MRI. And you can see nicely that it's outlined in green, your ligament. Get used to seeing what it looks like, because that's what we're removing. So that it causes narrowing in a space. You're removing that narrowing and you're making a patient feel better. The piled, it can be done on patients up to grade 2 spondylolisthesis. So some of the devices that are implanted, you know, you can't place those in patients more than a grade 1. So this patient can be, these patients can have up to a grade 2 spondylolisthesis. Next slide. So again, this is your MRI on the left. That's your sagittal view. You'll see your hourglass figure, or your hourglass on the slide. You can see narrowing. And again, you can confirm this with your axial view and see your more than 2.5 millimeters ligamentum flavum hypertrophy. This procedure, you know, it's not just for patients with stenosis. I mean, it's performed with patients with stenosis, but they have other comorbidities. So, you know, in my patients that are 70 years and older, they have facet arthropathy, they have stenosis, they have disc bulge. And having those other conditions doesn't make this a contraindication. You can still do this procedure on patients with those other comorbidities as long as they have greater than 2.5 millimeters of ligamentum flavum hypertrophy. Next slide. This procedure can be done for patients from L1 to S1. So this is different than some of the interspinous spacers. Those interspinous spacers cannot be placed at L5-S1, but the mile or the piled, you can remove ligamentum at L5-S1. This procedure is not contraindicated in our osteoporotic people. I have, you know, quite a bit of patients with osteoporosis, as I'm sure you do. We treat those kyphoplasty or treat those compression fractures quite often here in Florida. These patients can still have osteoporosis and have a mild or a piled performed because we're not placing an implant where the bone has to fuse, so it's not gonna fail. And you know, if patients have other comorbidities and maybe they can't have general anesthesia, maybe they're overweight or have other conditions, they can still you know, possibly be candidates for piled. Next slide. You know, these patients probably already exist in your practice. You know, you can perform this procedure on patients anywhere from a mild to a severe stenosis. You know, I've changed kind of the way I practice. You know, you could do this earlier in the disease state, so you don't have to wait till that patient becomes, you know, mild or severe and you're really pushing to take them to the surgeon. You can perform this procedure early on. Again, they're good for patients that aren't able to tolerate surgery. Their BMI is too high. I'm sure we all have those patients that you know, that are a little bit heavier. Severe osteoporosis is not contraindicated. If they have hardware at the level above and the level below, it doesn't contraindicate this procedure. So, as long as the hardware is not at the level you're performing. And again, remember, you can still do this procedure as long as they have less than a grade 2 spondylolisthesis. It's oftentimes in our practice, patients get seen and they have epidural after epidural after epidural, and it's not helping, or they've tried other procedures, and the piled can be very effective for them. Next slide. And then I'm going to turn it over to Dr. Jameson.
It's my turn. Okay. So we're going to go a little bit through an evidence-based algorithmic approach with some welcome or unwelcome side comments. Next slide. Okay, so we're talking a little bit about, how do we standardize this? When do we move on from ESIs? And I think there's a little bit of a wide variety of how people incorporate this into their practice. If we're saying that this is the same safety profile as an epidural, then I think at some point in the future, we may find ourselves considering this before or at the same time as epidural. In my practice, we do an epidural first, because I think we all have those patients, those little 90-year-old ladies who get one epidural and get like 9 months relief out of it. And you're like, I don't understand that. You have a mechanical problem. I can't figure out what the hell I'm doing with a steroid injection, but I'm winning today, so I'll take it. So, from my perspective, the least invasive method possible is typically best for the patient. But I have a pretty low threshold for moving on past that, again, because we're treating a mechanical process here, and I think that without doing something to alter the mechanics, oftentimes, as we're all well aware, we don't get long-lasting relief from epidural. So, and then this kind of this slide shows sort of this lowest risk all the way up to, of course, the open surgery for the higher risk. Although I was just mentioning before we got on today that I had a patient today where we sort of talked about all the options for your problem, right? And so I always say, well, the least invasive thing is physical therapy. And then we go from there. And the guy stopped me about halfway through and he said, why would I get an injection if I can just have this minimally invasive decompression? And I thought there for a minute and I said, were you planted here today? Did you know we were doing this webinar tonight? Anyway, so it is, I think it's a valid question, and one that we'll get more often from our educated patients in the future. In my practice, I still do an epidural prior to moving on to something a little bit more invasive. If for no other reason, then I can do an epidural next week, and I need a little bit more lead time on something like a piled. Next slide. So, like I was mentioning previously, there's not a lot of evidence for long-term relief with epidural steroid injections. Again, we are all very well trained to do these. This is what we do. We could do these with our eyes closed from across the room. Repetitive epidurals can provide some short-term relief for the radicular component of pain, and that can be very helpful, but they really aren't addressing the root cause of this stenosis, this mechanical compression that we're talking about. Next slide. In this day and age, particularly, I think we all have a little bit of angst about what the steroid does to the immune system for patients, and what that does and for how long. I think is a valid concern. I think Idaho just got named the #1 per capita in the country. We're the 49th for education and the #1 for COVID. Winning. Okay, next slide here. So this is the retrospective review that Dr. Rosenberg and Dr. I'm gonna mess it up, put together. And they essentially did a retrospective review looking at epidural steroid injections and the percutaneous interlaminar lumbar decompression at 2 different centers. And you can see that the characteristics of those patients were very similar. And the list of presenting spinal comorbidities is, of course, interesting as well, because as we talked about before, these patients don't just have central spinal stenosis and nothing else. And then their case info looked at the number of levels that were treated at one time. So, about half of those were a single level, and then the other half were 2 or 3 levels. And they looked at the levels treated. And that, I think, is not very surprising. I mean, when you're looking at an MRI, where I think we're all aware that you look at an L5S1 level, and it's pretty rare to have significant stenosis at that level, but it does happen. And then what do you have to offer that patient? So next slide. Yeah. Okay. So avoiding delay of care, I think, is always important for these patients. Typically, when those patients have come to see you, they have been experiencing far more than 6 months of symptoms. It takes them a while to get in. Most of them have gone through physical therapy, done these other things. And this graph goes to show that multiple epidural steroid injections did not show any advantage compared to either a single or no epidural prior to doing that procedure. And we just, we sort of all know from experience and from the data that cumulative effects of these don't exist. I mean, I remember when I first came into fellowship, everyone was doing a series of 3 for everything. And there was this sort of thought process that, well, everyone has to have 3 before you can say it's not working. And I think, you know, a lot of people have moved away from that because there's no evidence. I mean, I guess it's insurance patients come back and you get meet your RVU goals, but that's kind of about it. And so when we're thinking about how do we improve these patients' lives and how do we do it in the fastest way manner and most effective way, I think that the multiple epidural steroid injection is kind of a thing of the past. And so we have these other options that are safe and are very effective as well. Next slide. So treatment option number 1 is to treat that neurogenic claudication initially upon that diagnosis. So there are people that are, as I said before, that are looking at that patient and moving straight to that percutaneous procedure. And I would argue that there's nothing wrong with that. I think that's a very reasonable thing. You've seen all of the data on the safety and efficacy of this procedure, and we know the lack of data on the efficacy long-term for epidural steroid injections. Option 2 is to move on from this initial epidural if the release is less than 50% or is not lasting long enough. In our practice, we have algorithms for everything. I mean, we have algorithms for low back pain, we have algorithms for sacroiliac joint pain, and that helps my advanced practice providers in particular to kind of know where all of these newer technologies fit within our continuum. And so in our practice, we do this initial epidural, and then if there's less than 50% or it's not lasting, we move pretty quickly on to the next step here. Next slide. So sort of in conclusion, using this data that we've just reviewed in order to create these algorithms, I think is crucial. We know that repeat epidurals sort of delay time of treatment, but that they are not very efficacious in the long run. We have other concerns about epidurals using steroids, about what that looks like for our frail patients, for our immunocompromised patients, for our elderly patients with osteoporosis. And then the experience mirrors the published data, and I think that's a huge thing. I mean, we all get very excited about new studies that come out, but the question we all have is, what does this look like in my hands? What does the clinical aspect of this look like? And so knowing that this procedure is just as safe as an epidural, I think is something that should really push us to include this in our algorithm as an option to treat patients pretty early on in that algorithm. And I think that one of the beauties in this, and we'll talk about this a little bit more later, is that comorbidities are really not a contraindication for this. And we'll talk a little bit more about in the next couple parts about sort of how do you introduce this into your practice, and how do you not really infuriate surgeons, and how do you have those discussions. And so next slide. I think I'm turning it over back to Dr. Schroer.
Okay, so we're going to talk about the procedure. Go ahead and next slide for me. So again, stenosis. I mean, the simple thing I tell my patients, stenosis, I equate it to being like a hose with water coming through. If you kink the hose, the water doesn't get through. And in this case, it's the ligament flavum that is putting pressure on the hose. And so on this picture on the top left, you know, you've kind of got that hourglass appearance, and that ligament is pushing and causing narrowing there. And what we're doing is debulking and removing that ligament and just opening up the hose, letting that water flow through. The procedure itself, you have a trocar that you place under fluoroscopy through the lamina. You remove that trocar, you have a portal, that's that device that sits on the skin. The depth gauge that helps keeping you from going too far, because, you know, like the previous speakers had said, the most difficult part about this procedure, or the highest risk, is just the epidural itself. Everything is posterior to the spine. And then there's different instruments that you're using. You know, the procedure itself, the incision, it's the size of a baby aspirin, it's tiny. So, you know, generally speaking, if a surgeon is doing a laminectomy, they have to cut through the skin, through the fat, through the muscle. They have to cut the lamina and then scrape some of that ligament and flavum out. So the patients are on their backs for weeks. You know, they're they're immobile. And this procedure, you do it, they go to a surgery center, they go home that night, you know, they're up doing the things they want to do the next day. And it's all done through the size of a baby aspirin. Next slide for me. So the procedure itself, I guess if we want to try to play the video. Let's see. So, I mean, this is the procedure, standard technique. So on the standard technique, you're starting off, you know, you do everything on the left side and then remove it and then place another incision and do it on the right. It's all done under X-ray. So you place your trocar and you're using AP and contralateral oblique views. This is the contralateral oblique. So the trocar is between the lamina. You dock it on the inferior or the superior surface of the inferior lamina. This is the bone ronger. You're going to kind of doorknob the bone ronger through the trocar, and you're going to take bites of the inferior lamina and the superior lamina. You can take pictures again in the AP to make sure that you're staying on the lateral side of the spinous process. You're taking pictures in the contralateral oblique. You don't want to go further than the ventral interlaminar line. So you're using your kind of boundaries to keep you from going too far. You know, you've placed your epidural to, you know, keep you from going past the epidural. So this is the bone ronger. Taking out pieces from the superior lamina. My staff gets very excited when I pull the tissue out from the patient, because you know, most of the procedures done and you're looking at the X-ray, but you know, when we're pulling out material, it actually looks like we're doing something. And a little bit of tissue goes a long way. So, I mean, you don't have to spend hours working on this patient. Typically, I do the procedure in about 30 minutes for a few levels, but a little bit of removal of the ligament, you know, you're getting a lot of improvement of the patient's pain. So on the standard technique, you do the procedure where you do, you know, the left side first, you switch levels, and then you repeat it for the right side. And I think we can kind of pass, I think we can go past on that video, maybe.
All right,
and
there we go.
Thank you. And now go to the next slide for me. The nice thing about the procedure, so there's the standard technique where you're going to do you're going to do 2 separate incisions, and then there's the streamline technique where you're going to do just simply 1 incision, and then you can pull your trocar back to skin and manipulate it just like you would a spinal cord stimulator trial. And the midline, the streamline technique, it allows you to use, you know, less contrast because you're using bony landmarks to identify where you need to go. You can do a single incision, so that's, you know, a little bit less pain for the patient, less risk of infection. And it also uses less radiation. And I can tell you, you know, over the last year, I probably did about 100 or so or more pileds. And I was pregnant for the majority of those cases. And so, like many of you that have gone through that, your radiation badge is measured constantly. So every month somebody was collecting my radiation badge. I had to wear 2. My radiation doses were never high. And, you know, I would do probably 5 milds a week. And I never spiked levels for radiation. So you can still do this procedure under pulsed and low dose and collimate and protect yourself and protect your staff. Next slide. So this is the streamline technique, and we'll try to play this video.
Lindsay, you got to unmute. Lindsay.
Thank you. I thought I did that. Thank you. The Streamline Technique, you're starting just like the other technique, you're starting 1 to 1.5 levels below the level you're going to go into, and you're going to go in a midline approach. And then what happens is you're going to pull the trocar back to skin, and then kind of push it over to the left or the right, and then be able to place it between the lamina. So again, this is saving you an incision. So instead of having 2 separate sides, you're just going to go right in the middle. And as you see, he's able to kind of pull the trocar back and kind of hug the spinous process on either side. I don't use, so I don't write post-op pain meds for this procedure, or I haven't needed to. Generally speaking, patients ice packs on their back that night, and do well with Tylenol. Patients, even using the Streamline Technique, patients don't really require much post-op pain meds. So thank you.
We'll have a chance to talk a little bit more about that towards the end, if anything else you want to add, Lindsay. So don't worry, we won't hamstring you. We're going to let Jess take it from now and talk a little bit about forging partnerships, and then we'll have a brief time for some discussion and answering any questions at the end.
And I think Lindsay and I are debating Aaron Kolodny on the single incision approach versus not next week. So that ought to be interesting, if not intimidating, to say the least. Okay, next slide here. So this is always, I think, a big concern with new technologies that are introduced specifically to treat things like spinal stenosis. I think that any of us who work closely with surgeons have concerns about this because, you know, honestly, it's not their fault, but they are oftentimes very concerned about handling complications, about what happens if I have to operate and you've done this, and are you going to take my patients? I think those are the top 3 concerns that we hear, and I think there's some unique ways that you can mitigate some of this, and we'll talk a little bit about this in the upcoming slides. But if you're going to go try to get the credentials to do this at your hospital, it's going to be something that you're going to have to consider how to answer those questions. Next slide, please. So these are some typical educational points that I think are very helpful when you're talking to surgeons. So first of all, we're saying this is an outpatient procedure. This is a very quick in and out procedure, and the safety profile, as we've said multiple times, is equivalent to that of an epidural. In addition, the technique is very similar to an epidural, right? So we're not learning a whole new technique and coming in and doing something like that. This is a very similar technique to the sort of things that we do every day as far as the access to the spine, right? So we're posterior, and that's kind of where we live in our comfort zone. When I initially tried to get this through, I thought this is going to be no big deal. My surgeons are very understanding. They like to offer all these options to all these different patients. And for the first time in my career, I think they were not happy about this procedure, and I was totally broadsided by this. I thought, you got to be kidding me. So we actually sat down and had a discussion about what does this look like, who are the patients for this. And my junior partner and I started collecting patients and started saying, these are the patients. And today I had a prime example of a patient. I said to my surgeon partner, I said, hey, I saw a lady today with significant spinal stenosis. She's got a grade 1 spondy. It's not dynamic. She's got a 4.5 millimeter ligament. She's miserable. Oh, by the way, her platelets are 50 chronically. She's got horrible diabetes. She's got an A1C of 7.5, no matter what anybody does. Oftentimes it's 8.5 or 9. What else did she have? Oh, she smokes and she's on dialysis. And I said, these are the types of patients that I'm offering this procedure to, right? I'm not taking a 45-year-old who has single level stenosis and telling them that this is the only option for them, right? And so I think you have to have those sort of frank discussions with patients. Not that, I mean, quite honestly, I would prefer to have this procedure before I prefer to have a surgical procedure. But if you're really having an issue where you're trying to sort of convince your surgical colleagues that this is something that you should be allowed to do at a hospital that you're trained to do and that's going to help patients, I think a good place to start is to say, hey, we're going to start with these non-surgical candidates. We have proven outcomes. We have level 1 data. That's always very important. Oftentimes with our spine colleagues, they have much better data for the things that they do than pain tends to, quite honestly. And so saying, hey, look, we have level 1 data for this is great. Also saying this is not burning bridges. I think there's been a frequent kind of misnomer that pain docs go in kind of from this posterior approach and mess everything up so that when the surgeon goes in there, he can't figure out which way is up or down, right? We all sort of roll our eyes, but that was another sort of response that I got when I tried to get this approved at our hospital. And so I think having this discussion about how really, we really have no evidence for this, and in fact, we have more evidence from multiple surgeons who have gone in at a later date and said, if you hadn't told me that I had a piled, I would have had no idea, right? And so the other piece to this is that we really are addressing a big cause of the stenosis, and we are doing something from a mechanical aspect to improve these patients' lives, and we have proven patient outcomes that are that are longer than 3 and 6 months, which I think is important to point out as well. Next slide, please. And I think another part of this depends on your practice setup. If you're in practice with surgeons, a little bit different than if you're in an independent practice where you're doing pain and you're sort of dependent on these outside surgeons for sort of referrals back and forth. But I think that once you show a surgeon, I'm taking this patient who is an otherwise non-operative candidate but has significant symptoms, I'm improving their function and proving to you that I can improve quality of life and that these patients are doing well. And we're avoiding losing these patients due to the short-term effect of epidurals. I think that happens more often than we realize, where patients kind of just are getting minimal relief from it, or the relief isn't lasting and they just aren't coming back, right? And so I think that's a big piece of this as well. Addressing the neurogenic claudication early and optimizing these outcomes of these other procedures can be very helpful as well. How often do you have a patient that really needs a knee replacement, but the knee surgeon is saying, we got to do something about your symptomatic neurogenic claudication before we're going to go in there and fix your knee. And then to really expand kind of the whatever your network is, the patient pool there. So you're not burning bridges. If you need more invasive interventions, the surgeon can easily do that without having to worry about what they're going to find when they go in there, or removing anything for that matter. Next slide.
So this is the amazing time that we get to talk. First of all, let me just say thank you so much, Dr. Jamieson and Dr. Schroer. You guys were amazing. I am just so thrilled to be able to share something about a procedure that I'm so passionate about with my colleagues and with you guys helping. I feel like it's much better than me talking, because I'm pretty sure everyone's tired of seeing me on webinars. But that being said, I wanted to mention a couple things, and maybe you guys can comment. I know Lindsay had some other things. The goal of this was to help people evaluate and determine appropriate candidates for piled, understand the safe and efficacious way to do this for patients, and apply it in the algorithm, the basic tenets and the advantages of this Streamline technique, and apply the best practices for keeping these patients in your practice or maintaining great relationships with your surgeons. Now, that being said, particularly as we're functioning during COVID times and this pandemic has not seemed to ease up, one of the things that I think for me has been important, particularly in the beginning when things were shutting down a little bit, now as we're still able to do outpatient procedures, one of the important benefits of mild for me is that it was an efficient procedure. Patients are in and out the same day, so they don't have to actually stay overnight and utilize hospital beds. But also, most importantly, I think one of the things is that the reimbursement has recently improved significantly for outpatient surgery centers. So I think that's a couple things that I want to make sure that people were aware of. That being said, I know, Lindsay, you wanted to say a couple things, so I know we cut you off after your video discussion. What did you want to add there?
No, I think that this procedure, I just want to say it has changed the way I practice. I think it provides an alternative to just doing the same thing over and over and not getting any results. It doesn't require much in the way of post-op care. I think that's where I was going with that. You know, I don't write post-op pain medications. I generally have the patients follow me back to my clinic in about a week, you know, swimming. And then I get them started in physical therapy. And, you know, I tell them all of those muscles that have been weak from, you know, not being able to finish that full walk that you had to sit down for. You know, I get them back in a vigorous physical therapy program. And, you know, it's all about function and improving patients' function and get them going. And this procedure, I think, like everything, is a learning curve, but it's not impossible to do. And it doesn't, you're not stuck with it. So, you know, if your 1% chance that it doesn't work, it doesn't keep them from having to have a surgery later. So like you were saying about the surgeons, you haven't implanted something that you can't remove. And so, you know, it's not one of those things where you're like so committed to it that you can't back out of. And so I think it's a nice procedure that you shouldn't be afraid to do.
I love that. And I know, Jess, for you, this has been something that in the last year you've adopted into your practice. And I think, you know, you spoke so eloquently about how it's been something that, you know, you've talked to your surgeon about. When you think about just your surgeon, how do you, I know you're an amazing marketer. I model a lot of my marketing strategy off what you do. So how do you, now you've bought your surgeon, you've got his trust, he knows that you're gonna do this and you're not stealing his patients. How are you changing your marketing a little bit to your referring providers to bring these patients in so that they don't end up, you know, at a neurosurgeon or somewhere else, not in your practice?
Ooh, well, in the COVID era, that's really difficult. What I would like to do would be to do, I think that face-to-face things are always the best. And even if it's 5 seconds or 5 minutes or 10 minutes, face-to-face. And so going in and talking to the primary care docs, and honestly, quite frankly, the APPs, because I think that a lot of the APPs are the ones who are picking where patients are going, especially in a primary care practice. And so we do a lot of outreach to APPs. We do a lot of webinars to APPs. We've been trying to get that CME approved, but we're not, you know, we're private practice, so it's a little bit more challenging. But doing these kind of webinars for our APPs, they really kind of eat this stuff up. And so it's been very well received. And quite honestly, I think how many times can I say quite honestly, like in the same reply? All right, anyway. I think that when we are thinking about our marketing plan moving into the future, I think that we are starting to talk about direct to patient advertising. And I think that is a huge piece of how we will continue to market in the future. So we do these same webinars that we're doing for APPs for our patients. We send out email reminders. We boost it on Facebook for $100 for a week. And the last one we had 150 organic patients, right? So we send out the email to our practice, but then we also have, we had 150 others for a 1-hour discussion about treatment options for lumbar spinal stenosis. So I think those are some ways that you can get to those people. If you really want to talk to your primary care colleagues, I think what I did last week was I sent out just prepackaged cookies that I did not make myself, and some literature with a 1-page, this is what I have to offer. And I got pretty good feedback from that from some of our local primary care colleagues as well, because they have these patients. They have these patients that they know are not a good candidate for a big surgery, but maybe have tried epidurals, you know, 5 years ago and they didn't work, so they just didn't go back to the pain doc, right? So these patients are sitting not only in your practice, as Lindsay said, but also sitting in the primary care doc's practice, losing function and increasing opioid doses.
I love that. And you want to know something? I have to say that for me, some of this has actually been, I give this information to the patient, they look at the booklet, they're right away like, that's me on the shopping cart. And then they're actually going back to their primary care doctor and talking about, and then the primary care doctors are calling me and be like, hey, what's this thing that you're doing? And so then I take that opportunity to call them, particularly now. I mean, most of us aren't doing anything, we're just sitting around. So I take that opportunity to call them directly and just say like, hey, this is what's going on. This is what I'm doing. And, you know, suddenly, like, you've now initiated a bunch of referrals, like you just said, Jess, that people who weren't considering sending patients over because they failed epidurals, et cetera, et cetera. You know, so I think this is a great opportunity right now to do all those marketing techniques. I love that. I'm going to steal some of those for sure, which is why I asked you. The other thing is I want to make sure that people understand, one of the things, again, that I've talked about in the beginning, and I hate to beat a dead horse, but, this is a procedure that I think if you are comfortable doing fluoroscopically guided procedures that, you can be trained on. And the great thing is that currently we have virtual training available for anyone interested. It's easy to learn about, get started. You can also have a rep come to your office and do bone model training with you so that you can get your feel of the instruments. The instruments come in a pre-packaged thing, so your surgery center doesn't have to go out and buy like a bunch of stuff. It comes in this package from Piled. So realistically speaking, you might think, well, hey, nobody's doing trainings right now, so I've just learned a bunch of stuff and I can't go out and apply it. But we can actually get you trained sooner rather than later. And if you reach out to any of us on the panel, we'd be happy to put you in touch with people who can help you get trained. Now, that being said, I know that we've had our wine open and aerating for the last 51 minutes. These are some citations. If you'd like to have any of this data shared with you, please don't hesitate to let us know. Next slide. CME, this is where you're going to go. It's a CME. You are able to get your credit. Please go within the next 48 hours so that you can collect your credits and get that going. Thank you so much. If you didn't do this live, next slide, we can still have you watching the webinar and getting your CME after the fact. And it's so exciting to be able to get this 1.5 hours of CME based on this. Next slide. Other things we want to remind you of is that this is the conclusion of the CME. I have a few announcements before I introduce Ian Blackburn from Beekeeper, but we want to remind you that our dear friend Lisa passed away, and in honor of her, we established a scholarship through WIPM, and this is to help any WIPM member or pain medicine fellow early in their career physician who has a significant dedication to cancer research like Lisa. We plan on celebrating her too at our distinguished lecture series to be held at our 2nd annual WIPM meeting in 2021 at the Gaylord Resort in Denver, Colorado, assuming that everything starts to calm down. If you haven't made your reservation yet, hopefully things will start looking better in the next 8 to 10 months, and we can all do this together and hug each other. And I'm being super optimistic, but that being said, so we also want to remind you, if you are interested, coming up, we'll be having our awesome scrub caps with our WIPM logo. That purchase of that will actually go in support of the Lisa Stearns Memorial Scholarship Fund. And now with that, I know that everybody is super excited because I've already gotten some feedback via text, Ian, that your wine is yummy. So I am so excited to introduce Ian Blackburn from Beekeeper Cellars. Ian, I am going to turn my camera off and start drinking in shame by myself. I'm going to let you take the lead, and thank you so much for sharing your wine with us. I know we're all super excited, and away you go.
Well, fantastic. Thank you very much. My name is Ian Blackburn. I'm a professional wine educator, and I was very impressed that I get a little more time than any of those fantastic medical doctors that were just talking. And I learned a lot listening to this whole night, but I was really, really impressed with the presentation. You guys did a great job. I do presentations all the time, but with a wine theme, obviously, and I run a wine school. I have studied for my Master of Wine, did not yet pass that damn exam, but I'm still at it, and I love the pursuit of higher wine education. I've traveled the wine world, and I started making my own wine in 2009 after making wine for others since the 1990s. I've been involved in wine pretty much my whole life, and I worked for some top Michelin star chefs, namely Thomas Keller and Joachim Splichal here in Los Angeles. And I run the wine school called Wine LA. Along the way, I just really wanted to have my own opportunity to make my wine, and it is called Beekeeper, which is named humbly after my family, who comes from a pretty poor background of starving artists and entertainers. Kind of a early vaudevillian type of thing. So we kind of crafted the label to look like a an 1800s potion bottle, actually, which is probably what my great-grandparents were selling here in the United States when they immigrated. So that's my Beekeeper label. That's what's in the glass, and we're going to talk a little bit about this wine and the production technique, but it is Zinfandel, and it comes from really special vineyards. These are high elevation, dry farms that are California certified sustainable. And I make this wine at my best friend's winery. If you've ever been to Dry Creek in Sonoma, you might have visited my friend's winery named Clay Moritzen, or Moritzen Family Wines. Clay is an absolute phenomenal guy, and I wouldn't make the wine without him. I couldn't, because this is his family's vineyard. I get a particular slope, and I'm going to teach you about that. And we've established the Beekeeper brand to be a premium Zinfandel producer from high elevations, and just a super teeny little artsy project. But let's go ahead and go to the next slide. Unless I get to do that, I'm going to go ahead and try. Did not work on my side, so I'll let you change the slide for me. All right, there we go. So if you've never been to Sonoma, of course, Napa is just on the other side of the hill over here to the right, but Dry Creek Wine Valley, which is famous for the town of Healdsburg, also is connected to Rockpile. In fact, Rockpile is part of the Dry Creek Wine Valley appellation, but in order to qualify to be called Rockpile, you have to be at elevation, at least 800 feet in elevation, and it has to be from a hillside. So that's it. Go ahead and let's change our slide. I see. Now it's working. So I changed it twice. I'll go back one. There we go. So this is the Rockpile Vineyard. It's a tree on the very top of the hill, looking down on my little spot called Madrone Spring, which is a 2.3 acre little hillside. It's all stone. As you look out, you're looking due west, right at the ocean. And about 3 in the afternoon, some pretty good winds start blowing through town here and remove a lot of the topsoil. So it's real. These vines are really struggling to grow in a very stony spot, and it's a pretty extreme growing area. And there's really no life out there, no way to build a home. There's maybe 1 or 2 really adventurous cabiners out there, but not a real pleasant place to live from a convenience standpoint. The grapes love it. And I also have another site at 1,500 feet called Montecillo, and it is in the Sonoma Valley. Often a lot of people look at the name and say Monticello, which is another famous name, but Montecillo, in a literal translation, means up on a hill close to God. And this is just a really amazing vineyard. 1,500 feet is a really important number too, because we're right at the inversion layer, which is usually where the fog kind of lies, right up to about 1,500 feet. So we sit just above the clouds, and we get this really unfettered sunshine early in the morning, but also throughout the afternoon. And then some days we just get this really beautiful kind of patina in the vineyard with these fog and the clouds. It's just a super special spot. And this is a little look at the technical side of my wine, which is a Zinfandel based wine. We do add a little bit of Petite Sirah. In fact, in that Montecillo vineyard, we actually have a little bit co-planted. And so at the end of at vintage, we pick the grapes, we isolate the different lots, the free run juice, the Zinfandel, the Petite Sirah. We press the juice and then we barrel down. So we barrel down free run juice, we barrel down some first press, some second press, some third press, and we compose a blend based on press fractions as well as Petite Sirah. And I play around as much as I can with it to orchestrate what I think is the best representation of the vintage. In this particular wine, I get to blend both hillsides together too. And it's usually from my fanciest wood barrels. I go through and taste all the wood barrels, and I pick out a couple of my most distinguishable barrel lots to be able to blend this wine together. This particular vintage had a total of 9 barrels, 225 cases. And so it is a blend of about 75% from Rockpile and the GT Vineyard and my Madrone Spring. So this one is actually 100% Rockpile in 2017. And then each year is a different story. You know, we've had some crazy things happening in California. 2017 gave us really beautiful and dramatic fruit, but we did have some concerns after harvest with fire. Then 18, a little concerns after harvest with fire. And in 19, a little concern after harvest with fire. It was 2020, that we had fires during harvest, and that wasn't a good thing to have happen. In fact, the smoke just was so thick and so heavy for so long, and also with the COVID issues, getting the vineyard workers to go and pick is a real challenging harvest, and we will not make wine in 2020 because of it. So again, just another look at the Sonoma Valley appellation. A lot of really interesting wines are grown in Sonoma Valley. When you think of Napa, you tend to think of Cabernet, but when you think of Sonoma, it's really a very diverse appellation, and there is some beautiful Cabernet in Sonoma, some amazing Pinot Noir. In fact, I think it's some of the best Pinot in California, and also Chardonnay is supreme, especially from areas like the Sonoma coast. And then Zinfandel is potentially our #1 grape. And I really started making Zinfandel because I was passionate about it. I also am a winemaker for my whole life. I'm not a guy that, you know, finished my tech career and retired into wine with a small fortune, because that's what it takes to get in the wine business. I started very small and just continued to build my production as sales allow. And so today I sit at about 1,000 cases total in production, which is just absolutely teeny. But it's the only way to go for me. And I really just want to make great wine. I don't want to make a lot of wine. And so growing the brand slowly, I've got another 5 years to get me up to about 2,500 cases. And I'll probably come up a little bit short unless some economic miracles come along. But it's okay. I've got some time, and I'm going to keep building the brand, and I love doing what I'm doing, and it's just a really fun adventure for me. So I'm going to skip this one because that dot is actually in the wrong spot. So we're going to move on to show you what the Rockpile Vineyard looks like from the view of a drone. And that's how severe the slope is. And it's a workout walking up that hill. Now, this was taken when the vineyard was really, really young. Now, since '98, it's 22 years old. So the vines have really, really gotten past their infancy into more of a mature state of mind. But because we're dry farming, that is just like, you know, as you can imagine, taking care of patients and such. When we dry farm vines, they actually get stronger because they're not counting on us. So they really develop a mentality that they're out there to survive on their own. And so they dig down deep in for water resources, you know, obviously some sort of a nutrition. And as you go over the top of this hillside, right down onto the other side is a giant lake feature called Lake Sonoma. And that's a man-made lake, but it's huge. And it actually created a little cooling effect, which has really elevated the grape growing conditions here, because we have just amazing diurnal range. That's the difference between daytime and nighttime temperature, which is one of the reasons why my wine has really nice acidity and balance. Now, a lot of Zinfandel producers, and this is really my niche, is that I come from a winemaking background of making very dry Bordeaux style wines, working for the wineries that I work with and for. And so I really believe in the greatness of Zinfandel. Now, a lot of people decided to make Zinfandel extra ripe and almost play off the raisin and prune aromatic profile. And those aren't the type of wines that I like to drink. I like to drink a more balanced wine, a wine that has good richness to it, but also has a dryness and good tension from the acidity. It's all about mouthfeel for me. It's all about aromatics. And you can only achieve this type of quality from really high performance sites. This vineyard right here, 2.3 acres, delivers me about 2 tons of fruit per acre, and it gives me a really small quantity of wine to make. I'm lucky if I make 250 to 400 cases of vintage from this site. And I've had vintages down around 100 cases as well in extreme years. So it's just a real passionate project. You have to be passionate to make great wine. And I'm just in it for the long haul, and I only want to put my name on something that I can be really proud of. Here's another look at the hillsides. Now, when we first planted the vineyard in 1998, it was originally set up with these water hoses, which gave it drip irrigation. It was in 2009 that we weaned it off of water, and that was actually a research project by Clay Morrison's brother to convert it to a dry farm vineyard. And so that's also a really unique feature of this site. And that's also affected my quantity in the first 5 years after we started doing that. The vineyard just took a nosedive in how much fruit it was giving me. And we went down to 90 cases, about 1.5 tons in 2.5 acres in the 2011 vintage because of weaning it off the water supply. And there's Clay and I slowly climbing that steep hill. I'll look over at the ocean again, just another view. Now, throughout the year, we're in the vineyard to measure, how much growth there is. We like to make sure the fruit's hanging in the right sweet spot. We also may do some adjustments in the vineyard, like pulling leaf or thinning the vineyard out a little bit to slow it down, or maybe to hang that fruit out in the sunshine to speed it up. It all depends on where it's at. Coming into the back stretch, those last 30 days are critical to what we can achieve in Rockpile. A little Zinfandel cluster. Now, I do live in Los Angeles, and someday when I'm considerably older and much more chubby, I'm going to retire up into wine country, have a little tasting room, and sell my Beekeeper direct. But right now we're exclusively focused on selling our wine to top restaurants. And I had until March 225 restaurants, 25 of them with a Michelin star hosting my wine. But I only sold my wine in California, California, Arizona, and Las Vegas. And I was heading into Oregon and Texas when things shut down. So I lost 100% of my distribution into the marketplace, but that also opened up some opportunities. And I started reaching out to my mailing list and letting them know what was happening. We've kept the wine available on our website, which is beekeepersellers.com. And we continue to sell wine direct to our consumers. And then I entered into a couple of retail opportunities with some famous retail stores that said, hey, this wine's never been available today. We're going to offer, about 50 cases. Who wants some? And they sell it out in a day. And that has been really phenomenal for us. It's been able to, reach some new people. The wine that's in your glass, the 17 Hidden Hillside Reserve, has been very well accommodated with some amazing press. That's really kind of how we market our wine, is submitting it for critical acclaim. Robert Parker, Wine Spectator, Wine Enthusiast, and many others. James Suckling, California Grapevine, and Purely Domestic Wine Report. Our wine typically scores between 93 and 97 points. and we have been the #1 scoring Zinfandel for the past 7 years in a row. And this 2017 vintage probably were some of our strongest and biggest scores, between 95 and 97 points by Robert Parker. And so those type of things really do help move the needle for a small brand like myself. And, you know, basically putting in front of great people that enjoy buying full-bodied red wines like this is the other way. And so Beekeeper Cellars is really the way to be able to buy this wine, beekeepercellars.com, if you like it. I do ship to all states that are legal, and we only have 3 wines. They're all Zinfandels, and we release them at different moments of the year. And we're basically just started selling our 17s in October. Of course, again, we lost all of our restaurants, so I have more wine to sell this year, but not a lot. Given that we lost the 2020 vintage, we really kind of are going to slow down and spread things out. And but we sit at around 1,000 cases, and that's kind of what we're all about. When I explore this wine in the glass, I just love this color. 17 is just so flashy and stylish. It did have a week of very hot, warm, 105 to 108 degrees for about 7 days in a row, which isn't too hot at all. We had one vintage about 10 years ago where we got up to 115, 118 for a couple of days. That's blistering hot. And the vines shut down, photosynthesis stops at around 100 degrees. And so if it's that hot for that long, you start to get some really exaggerated kind of character. But it was just kind of the optimal amount of heat at the right amount of time, at the right stage. And we didn't get any sunburn, but we did get some very small concentrated berries. And if you just spin that around and look at that color, it's almost black. And that's really, color is not necessarily the one thing that we look for in a great wine, but it just happens to be kind of reflective of what happened in 2017. Now, I do put this in 100% French oak. That's another difference between me and a lot of other Zin producers that use American oak. And in this particular wine, I put it in some really special, it's called T4, Terenceau, French Forest Terenceau, 4-year dry-aged wood that really slows the wine down and gives it this really lovely vanilla. And then you get this, super signature dark Zinfandel, black, like plum skin type of character. And what I want you to smell, if I wanted to make a jammy, overripe fruit bomb, I could do that from very inexpensive fruit. My fruit cost about $7,500 a ton by the time we sort it and get rid of, some unwanted berries. We're closer to $8,000 a ton. 1 ton of fruit gives me 2 barrels, about 50 cases, about 600 bottles. So that's how it works. We just take a really hands-on approach, slow things down, look for quality, do a high selection, really small fermentations, very careful blending, and it's all done by hand. I am involved not every day, but the Moritzen team babysits my wine every day, and I'm out selling the wine to restaurants and doing what I do in Los Angeles with my wine school. So, but I get to mother this brand and slowly raise it up like a nice, well-educated child, hopefully, and hopefully dividends will come in the long term. Now, let's talk about that finish real quick. That is some tannin that you feel there, and I embrace tannin. And one of the reasons that some producers go in more of a jammy, overripe style is to bake those tannins out and really leave that wine's finish kind of overly sweet. I'm not a fan of that. I want to show the grape as it is. I want it to compete with great Cabernet, and that's my customer. A customer that's really looking at, buying some nice fine wine, paying upwards of $100 a bottle for Cabernet. I want to lure them back over to Zinfandel and show them the value proposition. I want people to think of my wine at $75 a bottle as being a great value proposition, a 95 point wine that can age nicely and have just wonderful, this is a fresh new vintage, but you've got 10, maybe 12 years of continued improvement in front of you with this wine. And I think it's just a really great iconic expression of California. And I'm trying to be a leader in the category of Zinfandel, and this is what I do. And I'm hoping that some of you might have a question. Not seeing any, but there might be some there. Am I missing anything, team? I'm not sure if I'm missing something on my side.
We have not received any questions yet as you're doing your tasting, but if anybody has any questions, please put them in the question box.
Okay, fantastic. Well, I'll continue on another topic inside of making my wine, unless somebody has another comment or question. But the category of Zinfandel is important in California. It becomes less important as you move across the United States. But Zinfandel is only about 3% market share in the red wine category. So it's a small pond, and even in 1,000 cases, I can play in this market. And a lot of people ask me, why don't you make Cabernet? Why don't you make Pinot Noir? Well, there's quite a few Cabernet producers and Pinot Noir producers today. And so we're all fighting for, to make people see our wine, to taste our wine, to know about our wine. And I just felt I had a better chance to compete in the category of Zinfandel. The name Beekeeper, really important. My family, when they came to America, they were vaudevillian entertainers. And in 1851, getting into America, they literally had a rule, no entertainers. So my family told a generous fib and said that they were beekeepers. I learned of this story by my uncle, who had a radio handle of Beekeeper when he was in the military. And so he said, we come from a long line of beekeepers that never had any bees. And so I said, well, that's a fun story for the wine brand. I didn't want to name the wine Ian Blackburn. I didn't want to put my own name on it. I do sign the back of the bottle, but I wanted it to mean something else. And so when I did my research and I looked at the town of Blackburn, England, where my family comes from, right on the family crest, or not family crest, but the crest of the town of Blackburn is a big bumblebee, and they're known as the worker bees of England, a very modest, humble town in northern England. I hear the soccer team used to be quite good, but that's the family story. They came from a little bit of the Blackburn side of the family came from Blackburn, England, and that's the connection there. And then my mom's side of the family came from Germany, where they were the vaudevillian side, and they potentially had enough knowledge of bees because they may have used some honey in the potions and the elixirs that they probably were championing on stage as vaudevillian entertainers. And but I'm not sure how they came to decide to say that they were beekeepers as they came into America, but they did go on to nice careers in the entertainment business. And my grandparents, their children, my grandmother was a dancer her whole life growing up in New York. She attended the professional children's school and grew up with the Marx Brothers and traveled the greater Northwest most of her career. And that's where she met my grandfather. He was a stage manager and a dancer as well. And my grandfather worked for Bing Crosby and retired to California and got busy in Hollywood. And my grandfather was also a dance choreographer and worked on the movie The Wizard of Oz. So they ended up here about 1945, 46, as the war was hunkering down, and they really got set up in the Hollywood business. But prior to that, my grandmother's mother was a very famous silent movie actress, and so the dancing and singing continued for a couple generations, and they handed me a desire to make wine. So I celebrate my family with the name Beekeeper, and that's the story behind the brand. We've had a pretty interesting thing happen to us in the later part of our happenings. So as we went into producing a label, our first label that we generated, the 2009 artwork, I was in the business of importing Burgundy prior to making my own wine, and I got very inspired by the Burgundian ideas. That's why the bottle shape looks like a Burgundy shaped bottle. I wanted to position Zinfandel a little differently there, and so I chose that shape of bottle, and I chose a label that looked a little bit like a Burgundy label. In fact, it looked so much like a Burgundy label. A very famous Burgundy producer, Domaine Romancanti, asked me to cease and desist because they saw a little bit of their label inside of mine, and I quite humbly said, yes, you've definitely inspired my label. So that's where I came up with the label you're looking at now. It's been produced through a little bit of research with a couple of artists involved. In fact, the final label was designed by a street artist here in downtown LA, who's come on to become quite famous. He was featured in the movie Exit Through the Gift Shop, and he sketched this label. His name is Peter Greco, and he sketched this label by hand, and then we CAD'd it over. And then in future generations, when we moved off of paper, this new technology allowed us to print directly to glass. And that's how we got to where we're at, making this beautiful package. We won a gold medal for the bottle and the label design. LA County Fair gold medal, best package design. And we continue to submit our wine to different critics for their appraisal and review. But the most important people that taste my wine are new folks, and we'd love to hear and would love to connect with you. So thank you for tasting my wine tonight. I hope you guys had a fantastic event, and I'm here to answer any questions, but otherwise I've concluded my presentation, and I thank you for tasting my wine. I hope I see you in Sonoma someday at my tasting room at beekeepersellers.com.
Thank you, Ian. And we do have some questions for the audience. The first one is, what are the differences between Zins and Cabs?
So Cabernet, being a different grape variety, has different flavor spectrum and a different development. And Cabernet is absolutely the king of the wine market as far as total dollars. And, you know, famous people think of big red wines, they often think Cabernet first. And that's part of the problem I see, is that Zinfandel just kind of let Cabernet take that land, where Zinfandel used to be made more like the wine I'm making here. In fact, if you go back to the 1950s, 1960s, there was more Zinfandel and Petit Syrah planted in the Napa Valley than there was Cabernet. Zinfandel was brought here by the Italian farmers. It was planted throughout California, mostly during the gold rush. And you know, all the wine made prior to that was from other grape varieties that really weren't supposed to be making great wine. So they brought these grape varieties to California, Zinfandel being one of them. And Italians and the folks from Eastern Europe, they brought a bunch of different types of grapes, and Zinfandel really stuck with the population. It became known as kind of the Italian house wine, but that style was more drilling in acid, like a great Italian wine. And in the 1960s, these wines had 12% alcohol, 13% alcohol in the 70s, about 14% alcohol in the 80s. And by the 1990s, we started seeing brands go over 16% alcohol with Zinfandel and turn them into big jammy style wines. Now, I said that, And Cabernet has just started to do that too. So you get some really ripe, fruit-rich type of wines. And these wines are easy to enjoy and appeal to a big audience, but they're not considered like really refined. And so I think the wine industry is trying to niche everything and find audience. And these big overripe Cabernets just make a lot of people happy. And Zinfandels have done that too. But I think that on the more refined, elegant, food-friendly style, I want to see my wine sitting in a Michelin star restaurant, going with great food. And if you've ever been in San Francisco, Master Sommelier Yoon Ha featured me at Benu restaurant, and that's a 3-star. I'm also at Single Thread in Sonoma and some other great spots. So the long answer to your question is, what's the difference? Well, we both kind of tread on top of each other a little bit, Cabernet and Zinfandel. The style of Zin tends to go into that more overripe as a classic notion because it is a late harvested grape, whereas Cabernet tends to be a little more driven by tannin and more of a claret style. I'm bringing Zinfandel a little bit more into the Cabernet zone, as a lot of Cabernet producers are bringing their style into Zinfandel land. So that's where we're at. I don't know if I did a great job of answering your question, but I gave it a shot.
The next question that's come in asks if there are any good food pairings for this wine.
Well, at its young state like this, it's very fruit oriented, but as it matures in year 4 or 5, you'll start to really feel a little bit more of that stony minerality come through as the wine marries together. So in its youth, I think it's a fun wine to drink now. I think that some of my favorite food to pair with this wine is I'm actually craving a lamb. I go to a lot of Mediterranean restaurants, have lamb kebab maybe, some hummus, that kind of Eastern European flavor set, Lebanese, anything in there. Those are really fun flavors to play with Zin, because you can pick up in the nose of this wine a lot of the dried herbs and underbrush. And I like to play with those types of foods with this wine. But, being in some of the top restaurants, obviously when we were featured at Cut Steakhouse, and, my wine was actually poured by the glass. And I'm like, wow, that's going to be an expensive glass of wine. But I thought we would be, kind of at the super top of the range at $40 a glass. But we were actually the least expensive wine at the Four Seasons, and they paired it with some amazing Wagyu. We've had the wine at several top restaurants here in California, and I'm not yet distributed on the East Coast, but I sell most of my wine direct to consumers on the East Coast, and they say that they take it to a lot of ribs are fantastic with Zinfandel, a lot of steakhouses, and I'm trying to kind of influence people to test my wine with those Moroccan to Middle Eastern type of flavor profiles, because I think that spice set works really neat with my wine. One of my favorite restaurants in Los Angeles that carried the wine was a Japanese Michelin 3-star restaurant, and they served it with A5 Wagyu, and that was probably one of the greatest pairings I've ever had with my wine. I don't mind it with chocolate either.
Thank you very much, Ian. I don't see any additional questions from the audience.
All right. Well, I really appreciate you having me, and I hope that you guys enjoyed the wine, and know that you're tasting something that's really made with a lot of love and care and concern. All the details are there, and you can find me. All my information's on the back of the bottle. In fact, if you call that number, my cell phone might ring. I'll talk to you later, and thank you for having me.
Thank you very much, and thanks for coming, everybody. Have a good night.